So, want to get going on the latest CEO leadership series. Probably 50th time we've done this with a CEO spanning the last 5 years. Rachel, welcome.
Thank you. Thanks for having me.
It's my pleasure, honored. So, I'm going to start the way I always start with my friendly CEOs, which is an introduction not just to TailorCare, which is what you've most recently founded, but an introduction to you and the journey that led you to TailorCare.
Sure. Well, first of all, I'm excited to do this. And if I'm officially number 50, I feel like I should get a plaque for that or something. But congratulations to you for hosting all these and creating such a great set of viewpoints that you get to share out.
We
So
do give out awards, so you'll probably get
am,
something.
I'm waiting for my award. If it's a t-shirt, I will wear it for the next podcast. Back to topic. So yes, most recently, as in like 2.5 years ago, founded a company with an investor group focused on musculoskeletal care. And I'll tell you a little bit more about what we're doing at TailorCare and how we're really serving both seniors as well as the commercial population on their journeys to treat, back, muscle, joint pain, typically called musculoskeletal care, but also basically the general term of orthopedics. But I've been in healthcare for a long time. I was actually, as a college student, thought I was going to be an orthopedic surgeon and a biomechanics PhD, and took a different journey for a variety of reasons that are really not relevant for this podcast, but ended up back in healthcare at probably my second job out of business school, where I was just really passionate about how do you better design, at that point, devices to treat patients. I was a medical device person because I was a biomedical engineer. And I loved it. And what I really loved was actually not the designing of products, which I actually didn't do, but I really loved the building of businesses. And so I really took that leap. I was an investor for a long time because I thought that that was my way of being able to expand the breadth of companies with whom I worked. I discovered that the better way to do that is actually to sit on boards as an independent. So I do a lot of that now, but I really moved into the business creation and the business sort of operations piece. I started a number of companies when I
You,
was
you
younger.
can say you can say entrepreneur.
Yeah, I was, but the fact is, the first time I did it, I was actually in a large company. I was at Aetna, and Aetna hired me I was at the Carlyle Group where I was an investor and found a lot that I liked about it, but really missed being kind of in the weeds on the operations side. That being said, I really wasn't an operator. At the time, I was more of like a business development person who was doing deals and could, negotiate and structure all sorts of commercial relationships. I was running investor relations for a public company before then too. I mean, I had all sorts of random kind of roles where I started companies, but I hired people to build them. So then when I went to Aetna, I thought I was going,
Natural operators make for very good deal makers.
yes,
This is
or
this is
maybe
our curse.
I guess, it's like you have to realize where, when you draw the line on things, right? Because you can always continue to optimize that deal. And I think that's the piece that has been the challenge now of you always want to just tighten the screws a little bit more, but you realize that that's not always best for the business. But so I went to Aetna, started a bunch of businesses there, and then realized I liked it so much that I then started Bright Health with a bunch of people, three founders to be exact. And then ultimately that was a crazy ride. That's a podcast unto itself. But when I was there, in addition to running a number of different functions and building the markets and running our health plan performance and markets, I ultimately built out our risk-based primary care business, which was called New Health. And I was the CEO of that business for a number of years. That's really the only thing standing for Bright anymore. That to me was actually what led me to go and build TailorCare, because it was the first time that I was spending so much proximity to primary care and understanding the risk models and really the obligations for them in order to manage risk in a population across a broad spectrum of clinical areas for which they were either not trained or just didn't have the time to manage. And so when you think about performance of risk-based primary care and you think about what primary care providers are best served to do, it is really to serve a lot of the kind of, I'd say, core clinical areas and then really divert to the appropriate specialists. But more often than not, patients kind of expect their primary care to do everything. And so needs aren't met. So, fast forward, I left Bright. I took some time to decompress and realized that jumping into build something on the risk-based side, tackling only musculoskeletal care was a huge opportunity that really was unmet. The companies in the space don't do that. So we were creating really a business out of a white space that our customers are really enjoying, and I think is serving a huge set of needs.
What an incredible journey. I often use the word journey, and that it definitely applies in this
Yeah.
case. You've just traveled so far
Yeah.
and seen so much. Just downloading some of the lessons learned will be a task in itself, but I will do my very best.
Very kind.
So from always an entrepreneur, always a builder, approaching the art of creating value from a number of different directions, as an investor, almost as a clinician at one point, as a corp dev, deal maker, and then as a founder really of Bright Health, and now a founder again. But fundamentally, in terms of areas of expertise, managed care and delivery of care, are they both in your mind? So you think of those two blocks and you think of coordination of care maybe as in between, connecting those two blocks.
Yeah.
Is that how you think about it in your mind as an operator? Like, I know the payer side well when it's closed network, coordinated care. I know the delivery side well when it's, working with providers and dealing with patient issues. Although TailorCare, it doesn't sound like you're on the patient side. And so just how do you
Yeah.
organize in your mind your own areas of expertise?
Yeah. So we actually are on the patient side. We're not delivering care, but we are navigating care. But to your
Right.
question, the intersection of payer and providers is really where I sit. So I've spent a bunch of time, obviously, as I mentioned, at two very different payers, and in both cases, wasn't only looking at things
That's
like
right. Aetna as
utilization.
well. Right.
Yeah, Aetna as well. Wasn't only, and at Aetna, I was really doing things that were payer adjacent, right? I was building businesses that were really enhancing what they could do for their employer customers as well as their providers and network. Right, I was really building the core components of our payer. So I really understand what both makes payers successful, but really the operations underneath it. But I'm not an operations person, right? So I always say very clearly, um, the things that I bring to the table and the reason why this business was so appealing to me is one, it does bring together what I have done and built and managed from a payer perspective, but also understanding the clinical delivery of care. I had at Bright, I was, I had, I mean, several hundred physicians and providers rolling up into my organization, as well as a significant more number of those that were affiliated, right? Ones that for which we managed their contracts and we provided tools and services for them to participate in risk-based performance arrangements. And so I really understood what makes providers tick. And it's not just the economics. A lot of people say it's just show them the money and they will operate. That's not the case at all. I think that's a huge generalization and does a lot of disservice to what providers are really in the business to do, which is actually to deliver best care and to really make their patients better. And so being able to manage that piece with the economics of care delivery, which, driven largely by the insurance companies, is, I think, a really important intersection. And so that's really what we built TailorCare to do, is to operate there, to enable providers to deliver better care, but also to deliver better economics for the payers, because that's what is going to ultimately sustain our model, given the breadth and the magnitude of, payers' participation in our healthcare world.
I'm one question away from diving into TailorCare, but
Yeah,
just
no,
before I take the leap, because I think once I dive in, I probably won't get out for the rest of the podcast. So I just have one more macro question for you
Yeah.
about the space, given your experience. So I interviewed Liz Fowler as the former head of CMMI. She just resigned with the new leadership that's taken over. We've interviewed Bruno Piquin, who ran managed care across Florida for some of the larger insurers for many years. I just like to hear from different voices, and I asked Liz this question: what do you think is fundamentally, operationally, structurally missing or even broken in the risk-based model that has caused unintended consequences, maybe even hardship, maybe even failure, in more than one occasion? If you were in charge of CMMI, if you were in charge of Medicare Advantage and CMS in general, what would you build differently?
Yeah. So I think there's two key gaps or issues that we have. And it's not just a Medicare issue, but this is actually a Medicare Advantage plan issue as well. And it's really a measurement issue for all payers, whether it is, or all arrangements with payers, regardless of what product you're talking about. It's the fact that you're being measured on a measurement period that is defined by a calendar year. And calendar years do not, medical costs and medical conditions don't follow calendar years. It's very difficult when you're managing a patient to say, wait a minute, do I put them in 2024? Do I push them to 2025 because I'm going to have, some different math games. We see that particularly difficult when you're talking about longer episodes of care. Musculoskeletal care is one such example. People think about an acute situation, right? Which is you've got back pain. And so that back pain is something that you manage. Most people live with back pain for over a year before they actually go and contemplate even surgery, which 90% of the time is actually contraindicated, but we can talk about that a little bit more when we dive into TailorCare. That issue of prolonging somebody's care or accelerating somebody's care because of the math associated with the performance on a plan is horrible. Because what it does is it penalizes the individual who's suffering. Pain and function issues are significant, and it really puts the providers in a tough spot. So that's one big issue. I think the other
So
big
just reconciling the timelines of payment and incentive with the timeline of treatment and finding that they are often imbalanced.
completely.
Right. One is a 3-year treatment program, and I have firsthand experience. I'll refer back to this maybe more than once today.
So do I. We can swap medical stories if we want as
right.
brothers.
I'm going through my MSK journey as we speak, and I'm on month 4.
Oh, I'm
and
sorry.
as close to a cure today as I was 14 months ago.
Oh,
So
I'm
I can
so sorry.
definitely, that's okay. I'm learning. This is my industry, and I'm studying it from the inside. And I've seen, I don't know, at least 6 different specialists in different areas, from neuro to chiro to ortho to PT to pain, and some strange specialists that I couldn't even tell you what they represent. So it is, again, it's very much a patient journey. And so going through that journey in a risk-based model, what would I represent to the average specialist at this point, 14 months into it? Just use me as an example. Would I be a per member per month fee? Would I be a savings at this point, a bonus that different providers are sharing in? Would I be an unintended cost because I continue to draw utilization? How do you view someone like me?
So the providers are going to see you continually as somebody who is at some point likely to be a surgical candidate if they can't figure out anything else to do with you. If you see the surgeon, they will figure out a surgery for you eventually, particularly with the kind of duration that you're talking about. But really, providers are not at risk in the musculoskeletal space the way that they are in primary care and the way that they're starting to be in other specialist areas. It's really what the payer is thinking about for you. And the payer is sort of seeing you as a very expensive person. Musculoskeletal conditions are about a third. They're usually the top 3, number 3 often, sometimes in number 2, associated with cardiology and also oncology for all payers. It's a huge amount of spend. And the other issue, and the reason why it's so expensive, is that it hits everybody. So a third to a half of a population in a risk pool is going to have at least one musculoskeletal related claim in a year. And so when you think about that, those claims that's going to see a doctor, that's not going to be meaningfully different. But my expectation is that throughout that entire journey that you've had imaging, you might have had some injections, your PT is repetitive. Those add up. And then it's suddenly become very expensive. And when we talk to payers, and to me, it's the best clinical care. You do one of 2 things. You either accelerate somebody like you to surgery because you're an actual surgical candidate, or you really work with them to find some sort of appropriate therapy that does manage their symptoms. But at some point, if the symptoms don't get better, you need to find a different tact. And what happens is, depending on the path that you go down with which provider you talk to, you are just being set up on a very different journey. And those journeys can often be pretty extensive, can cost a lot of money, and don't always result in better outcomes.
So I'm enrolled Jan 1, member enrollment period open, and all kinds of actuarial and analytics are assigned to me, patient 0. And all of a sudden 12 months go by and they were completely wrong. My risk scores are much higher, my utilization is much higher, and multiply me by another 1,000 patients like me, circumstances changed, and all of a sudden there's a disconnect between what providers thought they were going to get paid, what payers thought they were going to pay, and the reality. Is that sort of part of the issue that you're getting at when you say asymmetric calendars versus service?
Well, so not really. In terms of the calendars, as long as, and this is going to be my second complaint, as you asked me, what are my big issues and what.
Keep going. This is great.
It's on the claims data, right? So we don't get information about patients or members, a population for months after something happens, right? We all know this. This is a huge issue, but it really drives a delay in terms of being able to get care. Now, there are technologies that can alert you when somebody is admitted into a hospital or for a prior auth, right? We get all that data. Prior auths are great sometimes, but sometimes people don't do a prior auth, or they do a prior auth and they're admitted that day. So we have a real delay in information. And that is, I think, the second very big problem. In the situation you're describing, in our model, and everybody is different, right? We're not a network provider. So, and what that means is that when we work with insurance companies, we are not delivering care and billing them on a fee-for-service basis. We are actually working in a risk-based model with that payer, and we are just navigating people into providers in their network. Why that's better, it's easier to implement, but it also means that we're considered to be a partner, and we get access to all of the data around the patients, which network providers cannot get. So what happens is we have access to full claims data, not just musculoskeletal, but total claims data for a population. We get them on a monthly basis. So again, there's a month period for which something is delayed. We also get data, and then we get other data in the market. That data is daily. So when you're talking about your patient zero, right? That first month, if you're a new patient into the plan, I know nothing about you unless I can figure out ways to get information from other data sources. That's one of the things that we are working on.
Rachel, define data for me in the audience.
So data would be a pre-clearance for physical therapy sessions, or for a surgical event, or for an imaging.
Utilization management.
Utilization management, exactly. So prior authorizations, right? When you think about something that has to get approved by the insurance company to pay, they've got to submit it, and we get that request for submission. And more often than not, we use that to act on an intervention, so that if we see somebody is going down the path and they've got a prior authorization, a request to get an MRI, we will then look at that and say, wait a minute, does this person need an MRI? Should we just go talk to them? Let's do outreach to them and figure out, because we'll see what the MRI is for. And particularly if it's something like a back pain, where we know where MRIs lead to. MRIs often lead to surgery, but there are a lot of things that you can do between, zero and MRI and surgery to help somebody with their condition. Vast majority of times it works. Sometimes it doesn't. And then that person should go to surgery, but it's worth spending the time.
So let me try to be reductive again here, which is the only way to be with you, because you're the opposite of reductive. You are eternally highly technical and really sophisticated. So there's a whiteboard, and you see health systems, you see provider groups, you see primary care groups, you see orthopedic groups, MSK groups, and none of them seem to be particularly focused on excelling. Sorry?
Well, you forgot the patient on the whiteboard. The patient is the most important person on that whiteboard.
Okay, add the patient too. But I don't necessarily expect the patient to understand UMs anytime soon. So there is this complex full risk-based payment program up and running, managed care, MA, and none of those groups appeal to you as best in class in solving for optimal coordination of care. They all seem underwhelming, under-resourced, distracted in other ways. And so I'm sort of the lead into TailorCare. Mm-hmm. You're seeing this whiteboard, and there's this missing piece for a group that really wants to focus on bridging what's being offered by the payer community as potential incentive, potential reward for good decision making, versus what should be happening on the delivery of care side in response to that, but isn't necessarily happening because that lack of coordination. Does that come close to how your whiteboard moment, your eureka moment transpired?
I would say not really, because I think the most important piece for us is actually the patient and the patient experience. And you'd be surprised, patients start understanding utilization management when they get a claim, when they get a procedure denied. That's the first thing, and it creates a lot of friction. What you're describing, I think, is a more negative view of the players in the industry. Everybody wants to get it right.
I'm leaning towards profit optimization. Is that what?
Well,
what
I
you're
think
saying?
you are implying
economics.
You were implying that the payers don't know what they're doing, and the providers don't know what they're doing, and the specialists don't know what they're doing. They all know what they're doing, but they are not set up or structured to be able to look over the entire, I'd say, journey or clinical journey of that patient within a specific specialty area. And so what you see with primary care providers are some of the hardest working providers. And as you know, we're going to be facing a bit of a shortage. And there's a lot of, I'd say, challenges that are facing primary care, but they are the ones who are generally front and center for particularly a senior population, which is where we started. They are just, sort of, I'd say, strapped for time. And from a training perspective, are not trained to understand how to triage and manage patients within specific clinical areas. And so what they're trained to do is to refer, right? It's sort of what I joked about when I was in business school as a sidebar. I remember taking a class, all those basic classes we had to take our first year. I'm not sure if you had the same experience. I took a class in like marketing. I took a class in cost accounting. I took a class in operations. And I remember this specifically with cost accounting, thinking to myself, this is great. I now know enough to know when I need to bring somebody in who can actually do this, because this is never going to be what I'm going to do. I think of it very similarly on primary
I just
care.
can't believe that you still remember that there was a cost accounting as opposed
Because
to
it was
just
such a
accounting.
shocker to me that there was an entire class on cost
Yeah,
accounting and
yeah.
internal. It was not my favorite class, clearly, but resonated with me in the sense that we all need to know enough to know when we need to get the experts in, because we're never going to be an expert on everything. Primary care is not an expert on every one of these areas. And that's the reason why we're seeing so many specialty businesses start up, right? And you're seeing that in kidney care, you're seeing it in oncology, you're starting to see it in GI and in cardiology as well, because there is that unmet need. But the providers that are the specialists, what I think of as the downstream, right? I think of the primary care as upstream. They're referring to us. We get patients from them. The downstream are the specialists to whom we refer. They can be everybody from a physical therapist, physiatrist, pain management, orthopedic surgeon, sports med, et cetera. Behavioral health. All of those folks know exactly. I mean, they're experts in what they do, and sometimes they understand the full range of what can be delivered in terms of musculoskeletal care. But there are sometimes they can't. Meaning, we often say, a surgeon sees a patient and they believe that they should always have surgery. That's not actually the case. Many surgeons use really good judgment and understand when somebody is not appropriate for surgery. Maybe it's a health issue or a BMI issue. Maybe it's that they don't believe there's going to be the great outcomes. But, generally, if somebody is a surgical candidate, they're going to say, look, if you want to have surgery, here's what I can do. Here's what the outcomes will be like. They won't necessarily push, have you done physical therapy? Have you done these home exercises? Have you tried injections? They don't usually look at the history of that. Not all providers are trained that way. But, and providers all perform differently. And you could be referred to Dr. Smith, and Dr. Smith may just not be as good of a doctor as Dr. Jones. And you just don't know that because your primary care provider sent you to Dr. Smith. Having some actual data and understanding of who is a better provider for what you need is really hard to put on the individual. It requires a lot of research. It requires a lot of subjective information, better to be able to be navigated by somebody who actually has all of that data and can get you in to the best specialist who can manage your condition for what you need right now.
So I find it fascinating, interesting. There's no debate on my side with how siloed care still is in this country. And how could it not be if, and I have this conversation ongoing now on a regular basis with certain parties, every one of us as patients is not carrying real information on ourselves, right? We're all walking around. I see human beings on the street and I constantly think of them as born today, because from a medical history standpoint, we have nothing.
Right.
We don't carry our images and our history and what we did 4 years ago with us. And the industry that we've built, the solutions have been offered in siloed verticals. So as long as you're in network A, Mount Sinai network, you can find information. One Medical, you can find information. But we haven't bridged to create a holistic view. So there's no debate that care could be a lot more coordinated than it is. And I also think it's not enough to necessarily provide patients with full access to all their medical history in a moment's notice, a drop of water, a drop of a dime, because that's one directional. And what you miss is the bidirectional interaction with a group that's interested in their full medical history and is spending the time and the resources to engage with them on that level, as opposed to episodic care and even episodic continuous care. Like the latest high acuity chronic condition is still episodic. Yep. Right, in the context of a lifetime of medical treatment. And so it is interesting that you've raised TailorCare to this higher level. What I'm still solving for in my head is, and I also understand that primary care physicians, unlike concierge, You said stress for time, high volume of patients. You can only do so much.
Yeah.
But what I'm still solving for my head is why that role and how it functions within a
Yeah.
risk-based
Let me,
paradigm.
like,
And so when I'm a patient and I email you, which I did yesterday, your group, and I said, here I am, I'm Roy, get back to me, help me.
right.
Let's assume your team got back to me. Let's assume I was a perfect candidate for TailorCare. Let's assume
What
I was
happens?
I was a senior. Yes.
Yeah.
How is the sausage made on your
Yeah,
end?
so
What's
I was going to
happening
say, let
behind
me
the
take you
curtain?
guys through
Yeah.
what we actually do. And by the
Yeah.
way, even if you're not a senior, we have a large contract with another commercial payer. So we actually manage, if you are interested, we can get you set up. But let me tell you what we do, because it is, we're talking about the pieces, but at the end of the day, it really is kind of an end-to-end experience, right? So our customers are insurance companies and risk-based primary care groups. They're the ones that pay us, and we get
Okay.
paid in different models. It is a true risk model. None of this like, fluffy value-based care where there's like, upside and no downside. We take downside. We
Right.
were purpose
You
built for
didn't
risk.
just join an ACO and hope for an occasional bonus.
No, this is not a bonus program. This is a risk program. So for us to build something that was purposely designed for risk, we needed to make sure that we were, one, going to get the right patients in, and two, we needed to know what to do with them. So what we do is we actually get patients actually a bunch of different ways. We get them referred to us by primary care, as I mentioned. We get them referred by the specialists in the market, which we can come back to because it seems kind of counterintuitive as to why would a specialist, particularly in orthopedic surgical practice, send us patient volume, because you would think they'd want to keep their surgical volume. It's not the case. Actually, they really want to optimize for people who are really candidates for surgery versus people who
Right.
should take up their panel.
They're highly selective. I get that.
They are, particularly in the Medicare side, where they really don't get paid for office visits. We get paid through people who we cold call. We call them, we get, because of the information we have, we built predictive models to identify who we think is a good candidate for our program based on a number of key criteria. We can dig into that if you want. And we actually call them. And what you'd be surprised is that 25% of the time they engage in our program, which is like a shockingly high number. And I'll tell you a little bit about why that is in a second. Fourth
What would
way.
be an example of a group that you would cold call? I'm thinking like Padel members.
No, so we
Right.
would call, we have, well, let me tell you the fourth way. The fourth way that we get people is we actually send out mailers. We send out, pamphlets, we send out some magnets, and we get 6% of those people that get mailers from us engaged in our program. They call
That's
us.
amazing. That's
Amazing, right?
incredible.
Think about direct mail is like maybe 1%. Here's the reason why we get all these
A
people.
lot less.
Yeah, well, but yeah,
Point one.
you might know. I will tell you, it surprised me. I was not expecting
Six
it.
is unbelievable.
Yeah, here's the reason why. One, we are really good at targeting who we know needs our program. Because of the data that I talked about, we have built models to say, look, this person has this health history. We know we have a lot of clinical, both, experts in our company as well as around the table, as well as a lot of evidence-based guidelines oriented clinical approaches. We know what a patient journey is going to look like. There are many different patients, right? Many different patient journeys. Your journey is going to be different than mine. It's not like there's 5 or 6 patient characteristics. There are dozens and dozens, but it can tell us who is likely going to be going down a certain pathway. And do we think that that person should benefit from enrolling in our program, so we can ascertain whether they should go down, a specific pathway or not. So we target people really well. And the second piece of why we get such high engagement is that these are people who are living with pain and function issues. This is debilitating. So when you think about, like, again, going back to a primary care doc, if you've got a heart issue, that is urgent. There's life threatening, you need a clinical expert immediately. When you've got pain and function issues, those are life altering. And while there are downstream medical implications for somebody having low mobility, it is not going to be as urgent as somebody who is diagnosed with cancer or diagnosed with chronic kidney disease. As a result, those pain and function issues, that musculoskeletal care issues, get pushed down in conversations with primary care. They don't get addressed.
They get elongated for sure.
So
Yeah.
all the patients that we see, they're like, oh, there's somebody who actually can help me. This is
Yeah.
fantastic. So they call us or we call them. We get them on the phone with a navigator. Our navigators are licensed clinical physical therapists. Again, they are not delivering physical therapy care in our traditional model, but they are doing an intake, evidence-based guidelines. It's telephonic. It's literally like understanding functional issues, understanding desires, clinical goals, and really mapping
So you
them
deeper dive, you
a
have
deep dive.
a very well-informed network of solutions that you're also diligencing constantly with analytics. I imagine there's a deep analytics discipline flowing through your business, both
There's
from
data,
a,
data as
right,
well is really important because we need
right,
to
right.
understand not just what is most appropriate for this person, right? So somebody
Symptoms
may
and
say,
outcomes, symptoms and outcomes.
but it's also, we are not diagnostic based. We are sort of functionally based. What can somebody do functionally? What do they want to do functionally? What has been their health history? What are their goals? And how does that map to kind of their timeframes and objectives? And shared decision making is a big part of how we get somebody aligned on a pathway. And then we figure out and we get them to agree, you need to go down X pathway. A pathway could be go see a surgeon. A pathway
Right.
could be go do these home-based exercises and do virtual PT through our platform.
So you send me to a surgeon. I'm following you. I am.
Yeah.
I'm starting to understand the beauty in the art that you've created here with TailorCare. It's a painting, and you're like an artist. You're explaining it to me, and the beauty comes to life. So I'm really appreciating it. So you send me to a surgeon,
Yep.
and now I'm going to play the role of the surgeon, and
Yep.
I give one of your, I'm not going to say minions. I'm going to say colleagues. I give one of your colleagues a call and say, you know what, TailorCare, they recommended to patient X 4 PT consults or therapy sessions, and I think it's 8. I'm going to go with
So
8.
it doesn't work that way at all.
Right.
So what happens is if I think that you need to see a surgeon, I will match you
You
to
leave it at that.
I match you to the best surgeon, and that's because I
Mhm.
think you're a surgical candidate, not because you need PT. If you need
Okay.
PT, I'm sending you on a totally set of different pathways. But if you
No,
are
no, 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 no. My example still stands. Orthopedic surgeon, I'm going to perform the procedure. It's going to go swimmingly. But after the procedure, I'm going to diagnose, I'm going
the
to
surgeon determines that.
prescribe 8 PT
The
sessions.
surgeon determines that. That is not up for us
Okay.
to determine. We do not influence the direction of care once we direct somebody to a provider. We are behind the
It's
scenes talking to the patient if the patient needs help. More often than not, on a surgical pathway, we have a couple of touch points, but that person is under the care of the surgeon. They do prehab with that surgeon. They can use our platform to do it if they want, or they can do it, with whomever they want in their network. And then they do post-op work with that surgeon. Inevitably, they will come back to us because particularly in a senior population, they often have more than one condition. And so what we do is we help them with those follow-ups, or if they have questions around what the surgeon is telling them, or they've got questions about what to expect post surgery, that they're information they're not getting from the surgeons, we just step in and provide that to them. But we are not directing care, and we are not stepping in to determine what a provider should or shouldn't do. And by the way, when we get back to, it's up to for that utilization management for that payer. So if that individual provider says, I want this person to do 40 visits post-op of PT, well, it's really up to the utilization management program to determine whether that's allowed in their plan. If it's not, we can work with them to help them get approval for that. But more often than not, the surgical provider is going to do that. And again, that's not you think about it, it's an incremental cost for us. Yes, but this person, we've accelerated them to surgery versus having them go down a pathway where they're getting multiple images and doing physical therapy for years on end without any improvement in both pain and function. Accelerating surgery is often another way of accelerating and reducing accelerating clinical outcomes and reducing the total cost of care.
So if I had to list the value proposition from the perspective of a primary care group, so now I'm going to play the role of partner inside a large primary care group. I'm a former clinician myself, and my group has been taking risk for a while. We're large, and we also work closely with some counterparts in managed care, and they're aware of the network that we rely on, and everyone's using data to try to move patients along to the best clinicians with the best outcomes in a way that's high quality, low cost. And then TailorCare enters the room and says, I'm going to offer you the following. I recognize the part where you are taking an active interest in many more inputs in dealing with these patients where they would maybe demote and get frustrated with MSK options because it's hard. These things are riddles often, right? How to solve neck pain. So you're really engaging in understanding the patient's history and trying to design and tailor the optimal treatment plan with the optimal clinicians. I get that. But in
Yeah.
terms of,
I think your
but in
question is
terms,
why would providers refer to us? Why wouldn't they just continue down their normal referral pathways?
yeah, my question is, they are acutely attuned to cost and quality already before you've entered the room
Yeah,
because they have that incentive program lined up.
they have an
But
incentive program lined up, but it doesn't mean that they actually have got the right assessment of providers, and they certainly don't know in many cases how to screen for whether somebody is appropriate to go see an orthopedic surgeon or somebody who is appropriate to go see a pain management specialist.
so better screening. Again, I'm a
So the
simpleton.
value
I'm a
is,
simpleton in the room, so I gotta minimize these offerings down to like one or two words, A, B, C. So
yeah.
is better
Oh,
screening. B
so it's
is
better screening, it's better assessment of the network, and
yeah.
it's really a more seamless client patient experience where you know you're getting information back about that patient down that care journey. Whereas, the alternative is you refer to somebody and then you don't know what happens to that patient because that patient is now off on.
Okay.
So those are the
I
three key value props. And
I,
it really
I'm,
works.
I
It's
get I
highly
get
efficient.
A and C fully. B, are you running deeper analytics
Yeah.
or are you
We've got so
you
much
are?
data. So if you think about
God.
the data we have, we've seen close to 20,000 patients in Atlanta alone in the past year that have gone through our system that we have referred to specialists in the Atlanta market. We know a ton about what's happened to them. We know who's working well. We know who's not. When we start a market, we have to buy external data. But once we build in a market, we've got a ton of performance data. So that allows us to really evaluate and rank who is the most appropriate clinician for a patient and allows us to see performance, not just cost, but quality. We're just better at that because that's what
That
we
makes
do.
sense to me because you're a specialist. This is
Yeah. I
what you
mean,
do.
we're not referring to
A
20 different
primary care
specialties.
group would need to do this in cardiology and oncology
Exactly.
and
And
every other specialty out there.
right.
Yeah.
Totally. So, and what we
Okay.
also did, we also built an automated front end. We don't use it very regularly. We're actually starting to roll it out, which actually allows us to take on like a broad range of patients that may not just be in the part of the insurance company or the risk-based provider group that we're getting paid to do. So we actually have this kind of full end-to-end, I'd say automated process that gets somebody in and then gets them referred and scheduled, which is great. It's, very effective and very efficient. It does, to me, take out the personal relationship when I think about the value of technology and what we can do with, what we're building with AI. Don't underestimate the importance of the provider-patient relationship. That provider meaning navigator, primary care, whoever the specialist is. It's important.
I think Zoom is going to see a lot more video usage in its future just to
Yeah.
verify that the
Yeah.
person is there.
That there's an actual
Yeah.
person, right?
I think the more I learn about your business, and forgive me, it takes a little bit of time to unpack it.
Yeah. Sorry. I
Um,
maybe should have started with like, here's our end-to-end journey. I will tell
I still would have taken time. I promise you.
uh right.
It takes,
It's been a really it's been a surprisingly accelerated journey. We started this thing, as I mentioned,
it's a brilliant concept.
two and
It's
a
a
half years
brilliant
ago. We're
concept. Yeah.
managing several $100 million of risk of revenue of medical spend. We're doubling in size this year with committed, relationships. We bought a company at the end of last year to expand us into the commercial space, and now we actually offer virtual PT, which is again not like a core business that we're trying to build against Hinge or a Sword or some of the other large virtual PT companies, but it allows us to really accelerate the pathways where we can send people down highly integrated into our overall experience. We're just seeing a ton of traction because this is just an unmet area of spend. And
If you have proprietary knowledge on both ends, patient and delivery of care, and it truly is proprietary and unique and applied to such a large market of spend, you would think that at some point there'd be a lot of growth.
there is. And I will say that I keep coming back to the patient. Our patients love us. I mean, our NPSs are the 90s. We're showing them, percentage the improvement in pain and function, which is a kind of a standard measure for musculoskeletal care. If you remember all of your visits, they ask you to fill out that questionnaire of from a 1 to 10, how are you feeling? What's your pain? Can you get up? Can you sit down? All those things. Those are called PROMs. Our PROMs are showing significant improvement in over 80% of the patients that go through our program in both pain and function. So we're really seeing the results, not just from clinically adding value for clinically and economically adding value to the providers, but it's a great patient experience. And that makes the payers love it even more, particularly in a challenging insurance environment where everybody's hoping to keep their members. So it's been working out.
All right, so completely sold. I
Yeah.
took the
Great.
dive. Now I'm
Awesome.
coming out of the pool, totally sold. You build once again another great business, Rachel.
Well, thank you.
This
Let's hope this one has a better end than my last one.
that I don't know, that I leave to
Yeah.
other influences, other forces. But for what it is today, it's just amazing what you've built. I'm going to take the last few
Thanks.
minutes to ask you a couple more questions.
Sure.
It's of keen interest to me, this concept of coordination of care, because I don't feel like anyone's doing it that well. And so in the land of the blind, maybe the
Hmm.
US has one eye. And I'm not sure that most other countries have even that. So what's your view of coordination of care as a discipline from a global perspective? Are you
Oh
seeing any
gosh.
peers out there that you want to emulate that come out of Japan, France, Switzerland? Have you seen any signs of life when it comes to coordination of care? Because we have this really bizarre industry where we don't have to ignore we don't have to pay attention to the rest of the world. We can just ignore it.
Right. Yeah.
There's
Well,
very few industries you can say that about.
oh, yeah, we'll see how that plays out over the next few years. But I think that there are a few places that are doing that well in the US. I mean, look, if you look at
That's
this whole
fine.
concept of
That's
government,
an attached question. The US to competitors that you think of,
I mean,
examples that are out there.
but I mean, looking at places like a Kaiser or like a Geisinger, right? They were purpose built to actually coordinate care. They limit access to
Sure.
care outside of their network.
Yeah.
You have to make a decision about that, right? So I live in New York City, as do you. I
Yeah.
know that if a Kaiser existed here, I would not join it. Now I'm in, one of the fortunate that, as you are as well, we have the ability to choose our care and to optimize for where we think the highest performing providers are. Not everybody is that fortunate, and economics do drive a big factor in choosing care. So when you are faced with a dynamic like that, I think they're great options, and they're really high quality providers, in many cases, in more than many cases in those systems. Internationally, I think you see the same when you look at some of the government care, right? So you look at countries like France, like the UK, there is
Hmm.
coordinated care. But then again, it's exactly as I was just describing. Would you choose to have that as your sole source of care, right? Many people opt for private insurance who have access to that because they want to make sure that they're getting access to the highest performing specialists and have the flexibility of choice. And that's really about the flexibility of choice. To me, coordination of care in the systems that we have worldwide really restrict choice. And so you're trading off choice and, flexibility for kind of a shared coordination of both benefits, care, and experience. And I
I
think
think
that's
there's
important.
coordination of care in the UK from a public health perspective at a macro level with government budget in mind.
Generous to the word coordination, right? I'm being
Yeah, the
generous to,
primary goal is to maximize supply and access. The primary goal is
yes,
not necessarily to maximize utility
and
and
outcomes.
quality. Yeah.
No, that's absolutely the case. And so that's a fair pushback. I'm just thinking about kind of where coordination exists with respect to access to your health records and access to shared information, right? Which is something that in our system is still fragmented, even with all of the HIEs and all the other technology
Yeah.
platforms that have built out there. I think coordination of care is really challenging. And I think that the concierge models have attempted to do some of that. But again, that's a 1%er model where you're paying for somebody to be your coordinator. That is
Yeah.
not scalable. And so I think there's a technology issue.
The other challenge with concierge is I honestly think that you can't reach best in class care. And we're not there. I mean, we're there when everyone in the country has great care. So we've
Right.
got a long way to go. But the journey that we're on is more likely to achieve it. Why? Because individuals such as yourself are focused on the truth. The truth is not just the care that I give you, but the resources that I use in giving it to you. And my sense of concierge is that part of the equation, that other half of the coin, becomes irrelevant because it's luxury care. Luxury
It's
care is not scalable and never will be. And
I mean,
so we have to find solutions in the real world where resources are scarce.
and I
Uh,
mean, it's
and
not just
that's,
completely
yeah, go
agree.
ahead.
And you look at what people are developing in rural spaces and you look
So
at
they
what
don't care. They're not focused on the data analytics, the KPIs that you're focused on. Why would they bother? And yet
Well,
you're
I
building.
think that's where you're seeing. So look, what I'm focused on in the musculoskeletal space is super important because it hits so many people. But again, this is not the life-saving care that to me, there are people in our country who do not have access to life-saving care. That is a fundamental issue of our country, and that gets beyond coordination of care. That just gets to access. And so what I like to believe is that we are improving people's lives enormously, and we are creating
And you're doing it in Medicare. You're doing it in Medicare.
We're doing Medicare and we're doing it in commercial. We're not doing it in Medicaid.
I was going to say, I would be surprised if you were doing anything with Medicaid.
That's a different bird altogether. But there's a huge opportunity for, particularly when you think about seniors, which is why we started in that space. These are folks who, in many cases, are becoming more and more isolated because of their lack of mobility and because of their pain issues. And what that does for overall health and outcomes is horrible. So if you can actually get them improved and you can get them out of their house, there's a massive amount of health improvement that we are just starting to see. And that's part of kind of what we are hoping to prove to demonstrate as a result of mobility, as a result of reduction in pain, as a result of, what ends up being improved socialization, and behavioral health, observations and diagnostics, which we also do as part of our program.
Last question. We have 2 minutes.
Yeah.
Well, 2 questions.
I'll talk fast.
The last one is very quick. The first one might take a second or two. Stem cell therapy and GLP-1, transformational for the MSK space or peripheral?
Data is mixed, so historically one believes that obviously lighter weight frames, lower stress on the body, better improvements of outcomes.
But they're also more active.
But they're also seeing some of the studies that have come out with GLP-1s are actually showing higher rates of orthopedic related issues with people who are consumers.
More risk, maybe more muscle atrophy, and maybe the unknowns as well. And what about stem cell therapy?
Stem cell therapy is considered to be, and I have a feeling that you're asking me this not just as a professional question, but this is a personal question as well.
It's definitely a focus of mine.
Yeah. Right now. So when you think about stem cells, I've asked this question a lot because my own personal journey, which again is not for this podcast, but as I've considered whether stem cell therapy is beneficial, there are a lot of quacks out there. So if you're going to, there's not enough data to support it working efficaciously across the board. I think there is anecdotal evidence that it works for people. It depends on what is defined as a stem cell. And
lots of things work anecdotally for people.
So to me, have I tried stem cells?
Scary.
No. I'm a big believer in PRP. PRP clinically has been shown now to work. I think you're going to ultimately see that become approved as a clinical therapy for people non-surgical. I think stem cells is just not enough governance of what the therapies that are being delivered. If you actually want to talk about that for yourself, we can turn off the camera and schedule another call and I can give you some recommendations.
Calling you in 5 minutes. Did you have fun? Is my last
This is
question.
great. This is super fun. I always love talking to you, Roy, because you are a quick thinker. You ask great questions and you get to the kind of nut of what it is. So I appreciate it.
Thank you, Rachel.
Awesome. Take care. Thanks, everybody.